Bismillahirrahmanirrahim. This video is about different types of fetal anomalies. In fact, the fetal anomalies refer to unusual or unexpected conditions in a baby's development during pregnancy. We will discuss different types of anomalies one by one, but here we have list of those anomalies. And those include Anencephaly, Holoprosencephaly, Hydrocephalus, Spina Bifida, Encephalocele, the cardiac anomalies, renal anomalies, GIT anomalies, the torch infections, twin pregnancy, abnormal knuckle translucency which occur in Down syndrome, epilepsy associated abnormalities, diabetes associated abnormalities, the effect of the different drugs, cystic hygroma, omphalocele, gastrochesis, exomphlaos, congenital diaphragmatic hernia, meningomyelocele, duodenal hernia, choroid plexus cyst, echogenic bowel, ventricular magali, congenital pulmonary airway malformation, cleft palate and cleft lip, fetal hydrops, duodenal atresia, carry malformation, and the Porter's syndrome. Complex congenital anomalies refer to a group of heart defects present at birth. There are many complex cardiac abnormalities. A normal heart is divided into two sides, left and right, separated by a wall with a no gap or hole in it, and on each side there are two compartments, an upper and lower compartment. The upper compartments are known as atria, which receive blood. The blood is then passed to the lower compartments known as ventricles, which then pump it out. The blood from the right ventricle goes to the lung where oxygen is added and carbon dioxide is removed. This blood comes back through the left atrium into the left ventricle, which then pumps it to the rest of the body where oxygen is used. Valves control the flow of the blood into and out of the ventricles. There are two valves on each side of the heart. These valves make sure that the blood moves forward and not backward, especially between the contractions. The valve between right atrium and right ventricle is called tricuspid valve. The valve between the right ventricle and the pulmonary artery, which is the blood vessel taking blood to the lungs, is called pulmonary valve. On the left side, the valve between the left atrium and the left ventricle is called mitral valve. The valve at the entrance of the aorta, which is the blood vessel taking blood to the body, is called aortic valve. After understanding the normal heart anatomy, it's easy to understand the different types of congenital fetal anomalies which occur at different levels in the heart. Those congenital anomalies include atrial septal defect, tetrad fallow or tetralogy of Palate, ventricular septal defect, and aortic coarctation. Here we can see the aortic stenosis, a type of cardiac anomaly. This is the ventricular septal defect, a defect between the two ventricles. Above ventricular septal defect, here we can see the pulmonary stenosis. Every cardiac abnormality should be confirmed by an echo, preferably by a pediatric cardiologist or fetal medicine consultant, followed by karyotyping to exclude chromosomal abnormality. Abnormalities that are not compatible with the life, such as hypoplastic right heart, should be managed jointly with clinical geneticist, pediatrician, pediatric cardiologist, and the counselors. Now, what tests are offered when we suspect the cardiac anomalies in the fetus? The cause is unknown in most of the cases. Because of the associated chromosomal problems, pregnant woman is advised the amniocentesis, a test to check the baby's chromosomes. Can fetal cardiac anomaly happen again? The population risk for congenital heart disease is about 1%. The risk of recurrence is greater in the next pregnancy. In previously one affected child, the recurrence risk is between 2 to 5%. In case of previous 2 affected children, the recurrence risk is 10 to 15%. How is pregnancy managed? The pregnancy continues as normal, but the baby is monitored with a regular ultrasound scans looking for the complications that may arise as a result of cardiac abnormality. One of the complications include fetal growth restriction. How is the baby delivered with congenital heart disease? Most babies will tolerate labor and delivery without any problems. There is no need to do cesarean section for a baby with congenital heart disease. The baby with congenital heart disease should be seen by neonatologist immediately after birth. Now, the symptoms of congenital heart disease in the newborn depend on the type and severity of the cardiac problem. In such cases, the baby is usually not growing or gaining weight properly. There is either rapid breathing or difficulty in breathing. Baby becomes tired easily, and there is decreased breast milk intake due to becoming tired easily. Other signs and symptoms include excessive sweating, fatigue, rapid heartbeat, bluish tint of the skin, lips, fingernails, and inner lining of the mouth in a condition called cyanosis. Children with mild congenital heart disease may show mild symptoms or no symptoms at all. So, duodenal atresia is an abnormality in which there is blockage at the beginning of first part of the small intestine called duodenum. What causes duodenal atresia? There is no known cause, but it can be associated with other abnormalities. Approximately 1/3 of the babies with duodenal atresia will have chromosomal abnormality known as Down syndrome, also called trisomy 21. The reported incidence of duodenal atresia is 1 in 6,000 births. The double bubble sign represents the dilatation of the stomach and the duodenum. This configuration most commonly occurs with duodenal atresia and in annular pancreas. And annular pancreas is almost always associated with duodenal atresia. Here also we can see the double bubble sign. Here we have supine radiograph of an abdomen demonstrating a dilated stomach S and an accompanying dilated proximal duodenum, the D. There is no gas in the bowel distal to the dilated duodenum. This is called double bubble sign and usually indicates the presence of duodenal atresia. Because of this blockage, the baby is unable to swallow water, and as a result, the amount of the water around the baby is increased, what we call polyhydramnios. This condition is rare and occurs in around 1 in 10,000 births. How is fetal anomaly with duodenal atresia managed? Patient is advised another ultrasound by fetal medicine consultant to make sure that there are no other abnormalities associated with this condition. Then the patient is offered a test to check the baby's chromosome. At this stage, the test will be an amniocentesis. What happens next will depend on the result of the chromosomal test. If the chromosomal study is normal, the patient is asked to see the pediatric surgeon as well as the neonatologist to discuss the management of the baby after the birth. If it is abnormal, then she will have options to terminate or continue with the pregnancy. Does duodenal atresia recurs? This is unlikely to recur if it is isolated. By isolated, we mean that it is not associated with either structural or chromosomal abnormality. But if we detect any structural or chromosomal abnormality, this may influence the recurrence risk. And in such case, liaising with a geneticist will enable counseling about the exact recurrence risk of the genetic or chromosomal abnormality. Now, for the delivery of the baby with the duodenal atresia, I would like to say that it should be possible for a pregnant woman to deliver her baby in a normal way unless there are other reasons for requiring a cesarean section. The question is where to deliver a baby with duodenal atresia. The recommendation is to deliver in a unit where there is an expert to manage the baby after the delivery. How to care newborn with duodenal atresia. Because of the block A mother may not be able to feed her baby after delivery as it will vomit, and this may cause severe problem in the lungs including infections. Consequently, the baby will have a drip through which fluids containing nutrients will be given until the baby has had corrective surgery and is able to feed. Now, duodenostomy is the common surgical procedure for duodenal atresia. Here, the surgical bypass for the duodenal obstruction is done by side to side duodenostomy. Associated malrotation should be corrected, and that is called the LATS operation. In this procedure, the megaduodenum or anastomotic dysfunction can occur. Another procedure is duodenostomy, and it is only performed if duodenostomy is not possible due to certain reasons. It has got equivalent outcomes but more post-operative complications. Now, a little bit we should know about the pathophysiology of duodenal atresia as well, in which there is failure of canalization of duodenal lumen that result in improper formation of the vacuoles. As a result, atresia or web may occur, and there is accumulation of the gases and secretions above the blockage. Ventricular magali is a fetal anomaly, which simply means there is more than usual fluid in the baby's brain. Ventricular magali occurs when the fluid-filled structures called the lateral ventricles in the brain are too large. Normally, the brain and spinal cord are surrounded by a fluid called cerebrospinal fluid. This fluid, which is clear, is also found throughout the ventricles. The fluid cushions the brain and spinal cord from jolts and rapid movements, thereby protecting the brain and spinal cord. This fluid is produced in certain structures in the brain and flows through the brain and cord freely. When the ventricles of the brain are very large, that causes ventricular magali. Size of the ventricles in ventricular magali. This condition is diagnosed when the sizes of the ventricles measured on ultrasound scan are more than 10 mm. Sometimes the ultrasound will only show one of the ventricles even though there are two, one on the right side and one on the left side. Ventricular magali seems to occur more often in the male fetuses than in the female fetuses. Here we have the classification of ventricular magali. In mild form, the ventricular diameter is more than 10 mm and less than 12 mm. Moderate is when the ventricle diameter is more than 12 mm to less than 14 mm. And in the severe form, the ventricle's diameter is more than 14 mm. The incidence of ventricular magali. The mild to moderate types, where the size of the ventricle is 10 to 15 mm, occur in approximately 1% of pregnancies. What causes ventricular magali? There are many causes of ventricular magali, but in a large number of the cases, the cause is unknown. The commonly known causes include structural brain abnormalities, which are present in about 10% of the cases. Other causes include torch infections, fetal intracranial tumor, and hereditary conditions. What test is done to diagnose ventricular magali? The test which is commonly offered is that of the amniocentesis. Also, certain tests which help to find out the type of infection can also help us a lot. What is the outcome for the baby in case of ventricular magali? The outcome depends on several factors, including the actual size of the ventricles, whether or not there are other abnormalities on the ultrasound, and whether the baby's chromosomes are normal or not. In general, the outcome is worse when the ventricles are larger, the chromosomes are abnormal, or there are other problems seen on ultrasound. The best outcome is typically observed when the ventricular magali is mild and isolated, means no other problems are seen on ultrasound of the baby, and also the chromosomes are normal. The most common effect in the child is developmental delay. This seems to be related to the size of the ventricles. Doing a fetal MRI may help experts predict the degree of disability and may provide families with more information on what to expect for their child health and development. What are the management options for ventricular magali? In the first instance, there is the need to have a baby scanned by an expert in the fetal medicine. They will look for any other abnormalities that may have been missed. Secondly, the karyotyping is done to check the baby's chromosomes. If a patient doesn't want any test or if the test is normal, she will be asked to see a neurosurgeon for the discussion on what will happen after birth. Is there any treatment of ventricular magali during the pregnancy? There is no treatment before the child is born. After the birth, the management involves the symptomatic treatment of the child first of all. So, during pregnancy, we need to do the amniocentesis for chromosomal study, the MRI of the baby to check for additional problems. If the chromosomes are abnormal and there are associated with structural abnormalities, then the termination of the pregnancy can be offered to the patient. Now, what is likely to happen if a patient decides to continue with the pregnancy? In some cases, the baby will develop the hydrocephalus. In such situation after delivery, the fluid is shunted into baby's abdomen, that is called peritoneum, in a procedure called ventriculoperitoneal shunt. Now, what are the chances of recurrence of ventricular magali? That totally depends upon the cause of the ventricular magali. Where it is sporadic, the recurrence risk is very slow. If there is a genetic abnormality, then the recurrence risk will depend upon the recurrence risk of that specific structural or chromosomal abnormality. Talipes equinovarus or clubfoot is a condition in which a baby is born with his or her feet pointing downward and inwards. It is twice as common in males as compared to females, and the proportion is 2:1. It may affect one or both feet. 50% are bilateral, that is, it affects both feet. This may be isolated, that is, it is the only problem the baby has, or it may be associated with other problems which may be genetic, chromosomals, or abnormalities of some other parts of the body. What causes clubfoot? In most of the cases, the cause is unknown. There is, however, a familial tendency, means some members of the family have this genetic disorder. It may also occur in combination with other abnormalities. The associated structural abnormalities include poorly developed hip joints, spina bifida, the joint problems, or the muscle weaknesses. What tests are done to find reason for this abnormality? In small number of the cases, the baby may have chromosomal abnormalities. A patient may be offered test to check the type of the chromosomes, and that test is known as amniocentesis. Does Talipes equinovarus happen in the next pregnancy? The chance of having another baby with a clubfoot is about 1 in 25, that is 4%. In 1 in 1,000 cases, there is a chance that no other family member is affected. There is 3 in 100 chance of any other family member being affected. How to manage Talipes equinovarus? A patient is referred to fetal medicine consultants who scan the baby to make sure that there are no other abnormalities that have been missed. After chromosomal study and the detailed scan, an orthopedic surgeon will explain what will happen to the baby when it is born. How is the baby with Talipes equinovarus delivered? Clubfoot is not an indication for the cesarean section. The baby is delivered normally unless there is an obstetric reason for the cesarean section. Spina bifida is the abnormality of the spine. It occurs when the baby's spine and the spinal cord do not develop properly in the uterus, causing a gap in the spine. Spina bifida is a type of neural tube defect. The neural tube is the structure that eventually develops into baby's brain and spinal cord. There are 4 types of spina bifida. These are meningomyelocele, meningocele, spina bifida occulta, and closed spina bifida. Meningomyelocele is the most severe type, and here the baby's spinal canal remain open along with the several vertebrae in the back, allowing the spinal cord and the membranes that surround it to push out and form a sac in the baby's back. Meningocele is the second type in which the membranes around the spinal cord or meninges push out through a defect in the spine, but the spinal cord usually develop normally so that the surgery can often be used to remove the membrane without damaging the nerves. Spina bifida occulta is the most common and the mildest type of spina bifida. Here, one or more vertebrae are not formed properly, but the gap in the spine is very small. It doesn't usually cause any problem, and most of the people are unaware that they have it. Closed spina bifida consists of diverse group of defects in which the spinal cord is marked by malformation of the fats, bones, or meninges. In most of these, with a closed spina bifida, there are few or no symptoms. However, in few, the malformation can cause incomplete paralysis with urinary and bowel dysfunction. What is the exact cause of spina bifida? The exact cause is unknown, but a number of factors can increase the risk of baby developing this condition. These include low folic acid intake during pregnancy. Secondly, having a family history of spina bifida. Thirdly, the medications. Taking certain medications during pregnancy has been linked to an increased risk of having a baby with a spina bifida. Can spina bifida happen again? The incidence of the spina bifida, which is a part of abnormality collectively known as neural tube defect, vary with the age, race, geographical location, and several other predisposing factors. The incidence in USA is about 1 to 2 per thousand. The incidence in UK is about 4 to 8 per thousand. With folic acid fortification, the incidence has reduced to 25%. The risk of recurrence is tenfold without any intervention. How is spina bifida managed in pregnancy? It is managed by doing regular ultrasound scans. Some women may opt for termination of the pregnancy. Pregnant ladies are referred to the fetal medicine consultant who will rescan the baby to make sure there are no other associated abnormalities. How is the baby delivered? If there are no other complications and baby is lying the right way, there is no reason that the patient cannot deliver normally. However, if there are additional complications, patient may have cesarean section as the delivery option. Spina bifida on its own is not an indication of cesarean section. Can spina bifida be prevented next time? Higher dose of the folic acid is prescribed to those women who are at higher risk of developing the neural tube defects. And those women include the one having family history of neural tube defect, a partner with a family history of neural tube defect, diabetes mellitus, the patient taking anti-epileptic medications, etc. Holoprosencephaly is a birth defect involving the developing baby's brain. Normally, the brain divides into two hemispheres during early development. Holoprosencephaly occurs when the brain fails to divide properly into right and left hemispheres. What happens to the baby with holoprosencephaly? Where the abnormality is so severe, the babies tend to die before the birth, but in less severe cases, the babies are born with a normal or near normal brain development and the facial deformities that may affect the eyes, nose, and upper lip. There are three types of this abnormality, depending on how severe the abnormality is. These types are alobar, where the brain has not divided at all, and it is the one that typically is associated with the facial features. Another type is that of the semilobar, where the division of the brain into hemispheres is incomplete. The third one is lobar, in which there is separation of the hemispheres. What causes holoprosencephaly? Is it a hereditary condition? This condition can be inherited, but this is not always the case. Inherited causes include certain types of chromosomal abnormalities, especially when there is extra chromosome 13, a condition known as Petau syndrome, and changes in single genes called mutation that causes a combination of problems in the same person known as syndromic disorders. Some cases are sporadic, that is, they occur out of the blue. The genetic testings are done to answer to the questions patients usually ask. How is holoprosencephaly inherited? It depends upon the specific cause of the condition, but in non-syndromic holoprosencephaly, it is usually inherited as an autosomal dominant disorder. Here we have ultrasound appearance of the holoprosencephaly. On ultrasound, along with the monoventricles which are dilated, we also observe the fused central thalami. How is it likely to occur again in the future pregnancy? There is a small risk of this happening again, but this will depend on the reason why the baby had this condition. A genetic specialist will provide more information about the recurrence risk in the future pregnancies. Is there a treatment for holoprosencephaly? Each child has a unique degree of malformations. Treatment must be individualized. In general, the treatment is largely symptomatic and supportive. There is no specific cure of this abnormality, but where there are associated abnormalities, especially those of face, these can be corrected. What abnormalities are associated with holoprosencephaly? These abnormalities include cyclopia, in which there is single eye, median cleft lip, that is hair lip and palate, and missing of the front teeth. Those affected may suffer from developmental delays, seizures, and have a small head and multiple hormone deficiencies and feeding difficulties. These can be managed by appropriate experts with much support. Cyclopia is a rare form of holoprosencephaly and is a congenital disorder characterized by the failure of embryonic prosencephalon to properly divide the orbits of the eye into two cavities. It is the severest facial expression of holoprosencephaly syndrome. What is the life expectancy of someone with holoprosencephaly? This depends upon the type of abnormality. Those with the most severe form are often born dead. Less severe forms will be alive till the age of 12 months. Can its occurrence be prevented? There is no way to prevent its occurrence. If it is inherited, then there is possibility of screening the embryos before putting them in the uterus using a technique called pre-implantation genetic diagnosis. For this to happen, the exact gene or chromosome responsible for this must be known. Gastrochesis is a condition in which a baby has an opening or defect on its abdominal wall through which the intestine come out and all lying in a water that surround the baby, which is amniotic fluid. It is most commonly seen in younger mothers, particularly those who are less than 20 years old. The outcomes for the baby with this abnormality is very good, and the overall survival for the live-born infants with a gastrochesis is over 90% if it is the only problem the baby has. What causes gastrochesis? The exact cause of gastrochesis is not known. However, it has been proposed by different studies that it is more common in younger mothers and those who smoke. There is also an association with the use of recreational drugs. What tests are done in gastrochesis? Unless a baby has other abnormalities in general, no additional tests are undertaken on the mothers. This is because the isolated cases are sporadic, that is, there is no obvious reason for them. How to manage gastrochesis in pregnancy? First, the baby is scanned again by an expert, which is fetal medicine consultant. And if there is any problem, then the baby is monitored regularly with ultrasound scans, usually every 2 to 4 weeks to check the growth of the baby, as some of the babies with this condition may not grow as well as those without this malformation. The patient can also be referred to pediatric or children's surgeon who can discuss the management of the baby after delivery. How is the baby delivered? This condition is not an indication for having cesarean section. If the baby is growing well and the patient doesn't have any complication, there is no reason why she cannot deliver on her own. A significant number of women whose baby have this condition will go in labor before their due dates, and some may deliver early, that is before 37 weeks. It is ideal for her to have baby in a unit where there are surgeons to manage baby condition. Otherwise, the baby is transferred to such unit after delivery. Does gastrochesis happen again in the next pregnancy? Almost all isolated cases are incidental, meaning the risk of recurrence is low. If there are associated abnormalities, then the recurrence will depend upon those abnormalities. Is gastrochesis an inherited condition? Gastrochesis is not inherited, especially if it is not associated with any other problem. If, however, there are associated abnormalities, it would be necessary to check the baby's chromosomes. If these are abnormal, then the recurrence risk will depend upon the type of the chromosomal abnormality. In fact, an amniocentesis is the best test to find karyotyping in utero and to detect any associated abnormalities. How is a baby with gastrochesis managed at delivery? The baby's lower body is placed in a special clear plastic bag to make sure that the fluid loss through evaporation is kept to minimum. This also helps keep the exposed intestine moist. After delivery, surgery on the baby is carried out to replace intestines and to close the defect. Exomphalos or omphalocele is a condition caused by weakness on the baby's abdominal wall at the point where umbilical cord gets into the baby. Because of this weakness, the structures inside the abdomen, especially the intestines and the liver, may protrude outside through this point into the loose sac with a cord attached or inserted to the top of this sac. What causes exomphalos? The exact cause of this condition is unknown. Up to 80% of the babies with exomphalos will have other serious problems such as abnormalities in the heart and kidneys and chromosomal problems. What tests are offered in such case? First of all, a patient needs a detailed scan performed especially by an expert of the fetal medicine consultant so as to identify different abnormalities. Here we have an ultrasound of exomphalos showing abdominal wall defect, the amnion, the bowel loops, the umbilical cord cyst, or the Wharton's jelly. Now, because of increased risks of chromosomal abnormalities which occur in about 30% of the cases, a patient may be offered an amniocentesis in which a small amount of amniotic fluid is taken to help determine the baby chromosomes, whether these are normal or not. How is the baby with exomphalos delivered? There is no reason for not having a normal delivery. But if there is a chance that the structures which are lying outside are fairly large, the cesarean section may be offered to the patient. After the delivery, the baby is transferred to an ICU so that proper monitoring of the baby can be done. After the baby is born, the sac is wrapped in a protective film to reduce the heat and fluid loss. Baby is examined in order to identify any other problems. If there are associated lung problems, assistance may be required with the breathing as well. Is exomphalos an inherited condition? Exomphalos may be inherited, especially if it is not associated with chromosomal problems. If the chromosomes are normal, but there are associated abnormalities, the baby may have a syndrome, which is a combination of the problems. If the chromosomals or structures abnormalities are present, then the risk of the recurrence will depend upon these types of abnormalities. This table explains the differences between omphalocele and gastrochesis. In gastrochesis, the defect is located on one side, but in omphalocele, it is usually in the center. In gastrochesis, the contents are not covered by membranes, while these are covered by peritoneum amniotic membranes in case of omphalocele. There is no umbilical cord in case of the gastrochesis, while in case of omphalocele, the umbilical cord is inserted in the caudal area of the hernial sac. In gastrochesis, the contents include the intestines, colon, bladder, gonads, while in case of omphalocele, usually the contents include intestine, liver, spleen, colon, and bladder. Gastrochesis is rarely associated with other abnormalities which occur in usually 15% of the cases, while omphalocele is frequently associated with other congenital abnormalities which occur in about 40 to 80% of the cases. Congenital pulmonary airway malformation is a mass of abnormal fetal lung tissue that forms during pregnancy. This mass or lesion is usually located in one lung and it doesn't function as a normal lung tissue. Before explaining congenital pulmonary airway malformation, it is important to know about the normal number of lobes in each lung. Everyone has 5 parts of their lungs. These are known as lobes, with the 2 on the left and 3 on the right side. Occasionally, a problem occurs during development, resulting in one of the lobes containing fluid or spaces or cysts rather than lung tissue. These cysts can be detected on ultrasound before birth and have various appearances ranging from a small number of large cysts to a large number of small cysts. When this happens, the baby is said to have congenital pulmonary airway malformation. What causes congenital pulmonary airway malformation? The exact cause is unknown, but it is known that this is very rare condition. It occurs in about 1 in 10,000 babies. What specific tests are offered in congenital pulmonary airway malformation? Because we don't know the exact cause of this abnormality, there are no specific tests to find the reason why it happens. However, patient is sent to the expert in fetal medicine who do thorough ultrasound scan and thereafter offer the follow-up regular scans. Does CPAM affect the baby before delivery? Occasionally, the baby with this condition do not survive the pregnancy. More often, however, the cysts do not grow rapidly and may not grow at all. Does CPAM affect how and when will a baby be delivered? This condition is not an indication for cesarean section. If there are no other complications in the pregnancy, patient can be allowed to deliver in the same fashion as any other woman without having this condition. What happens to the baby after delivery? This depends upon whether the baby has breathing difficulties or not. Babies with the breathing difficulties are admitted in neonatal units to help them with the breathing, and sometimes surgery is performed. Now, the proportion of bronchopulmonary foregut malformation in CPAM is 30 to 40%, while it is 0.15 to 6.4% in case of pulmonary sequestration. The multiple lobes communicate with the proximal airway in case of the CPAM, while these are not connected to tracheobronchial tree in case of the pulmonary sequestration. The blood supply in case of the CPAM is pulmonary artery and veins. In case of pulmonary sequestration, it is systemic arterial supply, branch of the aorta. Venous drainage is via pulmonary vein or the systemic veins. The associated anomalies in case of the CPAM include cardiovascular anomalies, renal hypoplasia, chromosomal abnormalities. In case of the pulmonary sequestration, the associated anomalies include the cardiac anomalies, the diaphragmatic hernia, the gastric duplication. Congenital diaphragmatic hernia is a fetal anomaly in which there is a gap or defect in the muscles that make up the sheath that separates the chest from the abdomen, known as diaphragm. As a consequence, some of the structures that are normally in the abdomen, such as stomach, intestines, and sometimes the liver, push through this gap into the chest. Because of these additional structures in the chest, the baby's heart is pushed to one side and the lungs may not develop as well. Most of these hernias are on the left, but they may also occur on the right side. What causes congenital diaphragmatic hernia? The cause is unknown in more than 80% of the cases, that is isolated congenital diaphragmatic hernia. In less than 20% of the cases, the cause is problem with the baby's chromosome or genetic disorder. Here the baby may have additional medical problems or organ deformities. In an isolated congenital diaphragmatic hernia, the primary concern is how much this affects the development of the lung, that is, the degree of the smallness of the lungs or the pulmonary hypoplasia caused by the defect. In order to determine if congenital diaphragmatic hernia is isolated and to provide the correct information about the disease, genetic testing is required. And this testing is very important as the genetic and chromosomal abnormality will have implication for the outlook of the baby. Now, what tests are done to find the reason for this abnormality? The only test that can be performed is called amniocentesis, which allows for the chromosomes of the baby to be determined. In most of the cases, the chromosomes will come back as normal, and this is important as it means everything can be done to help the baby when it is born. Now, how will the baby be managed? So, for the management of congenital diaphragmatic hernia, there are centers in the world where the treatment in the womb is possible. This procedure is known as FETO, which is fetoscopic tracheal occlusion. The basis of this treatment is that baby's lung produce fluid that leaves the body through the baby's mouth. If this outflow of the fluid is blocked, it has nowhere else to go and as such swell up in the affected lung. As a result, the lung expand and its function appear to improve. This type of the blockage can be achieved by temporarily blocking the trachea with the balloon for a period of time. This is done through a keyhole surgery when a tube with a balloon is put down the windpipe of the baby and the balloon is blown up. The balloon is then deflated and removed with a tube at about 34 weeks of gestation. It is believed that FETO works by increasing the lung maturation and reversing some of the damaging effects of congenital diaphragmatic hernia on the lung function. Now, what to do if FETO is not available? In such case, the baby is monitored and delivered as planned. At the time of the delivery, every attempt is made to stop the baby from breathing on its own, as this will allow air to be swallowed in the stomach and stop the lungs from expanding. Surgery can then be planned close to the defect. So, a pediatric surgeon will closely see the patient and the baby and will decide how to close this defect. How much is the recurrence risk of congenital diaphragmatic hernia? The risk of the recurrence depends upon the associated genetic and chromosomal abnormalities. In case of isolated congenital diaphragmatic hernia, the recurrence risk is very low. How is baby delivered in congenital diaphragmatic hernia? This abnormality is not an indication for the cesarean section. A patient is offered cesarean section if it is indicated for obstetric reason. However, it is important that a patient delivers the baby in a unit where there are experts in managing the baby at the time of the delivery. Cleft lip is a birth defect in which baby's upper lip is not formed completely and has a gap in it. This may be on one side of the face or may involve both sides. A cleft lip may occur on its own or may be associated with cleft palate. Approximately 1 in 700 children are affected. What causes facial clefts? The exact cause is not known. However, it is associated with certain risk factors which include certain medicines during pregnancy, smoking during pregnancy, certain infections during pregnancy, changes in the genes or genetic mutations during pregnancy, mutated genes before pregnancy. How is facial cleft managed? A patient is referred to a fetal medicine consultant for further ultrasound scan to make sure that any other abnormality has not been missed. A patient is also referred to a neonatologist who will explain how the baby will be looked after when it is born. Does facial cleft affect how the baby is delivered? The aim is to deliver a baby vaginally. A facial cleft is not an indication of the cesarean section. What are the chances of facial cleft happening again? The recurrence risk in a child depends upon the severity of the cleft and the presence of the family history. The recurrence risk for the cleft palate on one side is about 2 to 3%. If it is lip and palate, the recurrence risk rises to about 4%. If the cleft and palate are both on both sides, then the risk of recurrence is 5 to 6%. If one parent is affected, the risk is about 4%. If both parents are affected or both siblings are affected, the recurrence risk is 10%. How to reduce the risk of recurrence? A patient is advised to take folic acid of 5 mg starting 1 month before trying for the pregnancy and continuing it until 12 weeks or after first 3 months. Folic acid reduces the risk of neural tube defects. Folic acid also reduces the risk of oral clefts by about 25%. How are cleft lip and palate diagnosed? Prenatal ultrasound can diagnose most of the clefts of the lips because of these clefts can cause the physical changes in fetus's face. After birth of the baby, the physical examination of the mouth, nose, and palate can diagnose the cleft lip or cleft palate. Amniocentesis is a specific test in which amniotic fluid is removed and that is tested for the chromosomal analysis. What is the treatment of cleft lip and cleft palate? Surgery treats cleft lip and cleft palate. The exact details of the treatment depend upon the extent of the clefts. And this chart explains the approach to the cleft patient. Prenatally, the genetic diagnosis is done. From birth to 3 months, lip tapping and NAM is done. In 3 to 4 months' time, lip adhesion and lip repair is done. In 1 year time, the palate repair is done. At 2.5 years, the speech therapy is done. Orthodontic treatment is done at the age of 6 to 9 years. Orthognathic surgery is done at the age of 16 to 18 years. Anencephaly is a major abnormality in the head characterized by the absence of most of the baby's head. Essentially, the upper part of the baby's skull and brain doesn't develop in anencephaly, that is, major part of the brain, skull, and scalp. The baby is therefore born without the front part of the brain, that is, forebrain, and the thinking and coordinating part of the brain, which is cerebrum. This abnormality is not compatible with the life. In fact, babies with anencephaly are stillborn, that is, born dead, in approximately 75% of the cases. Those born alive only survive for few hours, days, or weeks before they die. The remaining part of the brain are often not covered by bone or skin. What causes anencephaly? In most cases, the cause is unknown. There are, however, some cases in which the baby has an anencephaly because of the change in their genes or chromosome, or the mother has been exposed to certain factors in the environment, such as what she eats or drinks or takes, especially some medications in the early weeks of pregnancy. How does an anencephaly look like on ultrasound? On ultrasound examination of the fetus, the calvaria and the brain parenchyma are not visualized. The biparietal diameter and the head circumference could not be measured. A coronal section through the fetal face shows the frog-like bulging of the eyes and the absent frontal bones. What tests are done to diagnose the anencephaly? As some cases of the anencephaly may be associated with abnormal chromosomes, we offer an amniocentesis. Unfortunately, the tissue may sometimes fail to allow chromosomes to be determined. What is the treatment of anencephaly? There is no known cure or standard treatment for anencephaly. Almost all babies born with anencephaly will die shortly after birth. Does it run in families? Most cases of the anencephaly are sporadic, which means they occur in people with no history of the disorder in their families. A small percentage of the cases have been reported to run in the families. However, the condition doesn't have a clear pattern of inheritance. In some cases, it may be associated with a chromosomal abnormality, a severe malformation syndrome, or disruption of the amniotic membrane. What disorders are associated with anencephaly? The disorders that are associated with anencephaly include folate deficiency, maternal hyperthermia, trisomy 13-18, Turner syndrome, triploidy, amniotic band syndrome, limb or body wall defects, and Walker-Warburg syndrome. Does anencephaly recurs following the delivery of a baby with anencephaly? It is often estimated that there is 1 in 25 chance of this happening again in another pregnancy. This recurrence rate is essentially that for a neural tube defect, so the baby may have a spina bifida instead of anencephaly. Can anencephaly be prevented? There is no way to prevent this 100%. However, eating food that is rich in folic acid, that is getting enough folic acid before and during pregnancy, can help prevent the neural tube defects such as anencephaly. The standard recommendation is to take folic acid at least 1 month before a patient tries for the pregnancy and continue this for the first 3 months of the pregnancy. The recommended dose is about 5 mg, which is slightly more than 10 times the recommended dose for someone who has not had the baby with such abnormality. What are the options for managing this pregnancy? Patient can elect to continue with the pregnancy or go for termination of pregnancy. If a baby decides to continue with the pregnancy, she will be followed up regularly as there is a risk of having excessive water around the baby, which is called polyhydramnios. Furthermore, a patient may go past her due date, in which case we may have to start her labor by doing induction, with the risk of cesarean section as the baby may not be lying in the right way. If a patient wishes to have a termination of the pregnancy, this will be performed in a sensitive way as we will do in other terminations.